Okay, welcome everybody. My name's Sophie Scott. I'm the medical reporter for ABC. I'm going to be your host today. Thank you for tuning in and watching. Today we're going to talk about breast implant associated anaplastic large cell lymphoma. Now that's a bit of a mouthful, so we're going to call it ALCL for this debate. We want to make sure that everyone out there watching is up to date with all the latest information about this condition. Now, before I introduce our panel, we've already received lots of questions for the webinar, which is fantastic. We'll try to get through as many as we can. You can also ask questions as well, and they'll come up on my iPad. The briefing will be recorded, so if you don't have to take notes, you can play it back and watch it later. And we'd love you to share it on social media because this is such an important topic. If you're on Instagram or Twitter, we'll put it out through that. And my Instagram and Twitter handle is @SophieScott and the number 2, so I'll be posting it there after the event. So let me introduce our panel. Right now we've got Professor Anand Deva, a plastic surgeon from Macquarie University, Donna Anna Locke-Wilkinson, a plastic surgeon from Queensland, Dr. Ron Bezic, a cosmetic surgeon from Sydney, Anne-Marie Sage is our consumer representative on the panel today, and Miranda Laumann from the Therapeutic Goods Administration. So thank you all for being here, and I will just start by saying that the information that we'll be talking about today is general in nature. And if you have any specific concerns that you want to raise, you should raise it with your own physician. But you'll be hearing lots of good information today. So before we start, let's just set the scene with a couple of slides with Dr. Deva, maybe taking us through just where we're at when it comes to breast implants and this condition. So Anand, just take us through the issue of breast implants. How common are they and when were they introduced in Australia?
Sure. So look, they've been around for a while, introduced since the 1960s. They're used for both cosmetic enlargement of the breast and reconstruction, and they can vary considerably based on the shell, textured, smooth, what's in them, and what shape they are. We've known a little bit about... I'll just advance that slide.
Sure.
We've known about breast implants, and they're quite highly regulated, and they're classed as Class 3. So all the devices, they're the ones that are carrier risk, and they have to balance the risk versus the benefit. Now, it's really important for all Australian women to know that these devices are now tracked through a registry. Around 20,000 Australian women get these devices each year. And the Australian Breast Device Registry, set up by the federal government, monitors long-term safety and performance. So it's critical that if you're getting an implant, that your implant's placed in the registry. It's endorsed by all the societies and by surgeons. It's free, and certainly seek a surgeon that uses the Breast Device Registry. And then about ALCL, this is a tumour that was first reported back in 1997. And certainly in the last 10 years, numbers have been increasing. There have been 33 confirmed deaths from this cancer. And currently, there are at least 838 cases confirmed worldwide. And the reason we're here today is because Australia has reported quite a large number of these cases, 107 as of 31st of January this year.
Okay, excellent. So we'll just flick through to the rest of those. Okay, so let's get cracking on our questions. One of the most common questions that patients have asked is if someone has breast implants and they're worried, what should they do? And let's talk to the doctors on the panel. For a start, what are the symptoms that women should be looking out for if they have breast implants? So we'll just go through to our 3 doctors here.
Well, I think anything that changes in either shape, size, pain or a palpable mass would alert you to go and seek medical attention.
And Dr. Locke-Wilkinson, what should women be looking out for?
So one of the things if you have breast implants is look for what we call late seroma. So it's often a collection of fluid, usually more than 100 mils, but generally significant collection of fluid and usually presents in a delayed fashion. So.
And when you say delayed, so what do you mean by that?
Yeah, usually on average every sort of 6 to 8 years, roughly.
Okay, and Dr. Bezic?
Yeah, it can be anywhere between 3.5 to about 14 years, I guess. Yeah. The other thing, the key, often it occurs on one side most commonly, so any asymmetry, so any difference in the size of the breast that's slowly developed might be a key pointer. It's usually painless.
Okay, and so if women do have any of those symptoms, what is the next step then? What should they do in terms of getting those symptoms checked out? Who'd like to take that one?
Look, I mean, first, see your original operating surgeon be your first port of call. And an ultrasound is the first valid test that you do, and that's not invasive, it doesn't have any radiation, it's an easy test to access. And they can see if there's any fluid around the implant or if there's any masses that are obvious on the ultrasound. And they can test that fluid if there's enough there.
Okay, so and then what about, so the if there's, so we'll go into some of these issues a little bit more in detail in a minute, but if women don't have any symptoms and are concerned, what should they be doing?
So I think there's no indication to date, if you've got no symptoms in a normal examination, either physical exam or ultrasound exam, that you need anything done apart from ongoing surveillance. So I think that's key. And so I think initially a good assessment, ultrasound if required, and if everything comes back okay, then I think women can take heart that they're unlikely or probably don't have this cancer.
And so some women, though, some patients might want to have the implants out even if they don't have symptoms. Is that something that you're finding with some of the women that are speaking to you, that they do feel anxious and they want to have the implants out?
Yes, absolutely. So what we get a lot amount of women, they are sort of very anxious and they're thinking, oh my goodness, what am I going to do? I'm reading all of these articles, I'm seeing all these things in the news. And I think that with that fear comes that uncertainty. And I think having that check and really getting the facts about what to do is so important.
And we might just go to Miranda from the TGA, Miranda Laumann. So what's the TGA's advice about whether women should get the implants out if they don't have any symptoms?
So certainly the ongoing advice we've had from our expert clinician advisory group is that where there's no symptoms, where there's no clinical reason to have implants removed, that shouldn't be pursued. There are risks with having explant procedures, as there are with all surgeries. And so that risk-benefit is something that people really need to weigh up, but we'd encourage people to stay informed and definitely to keep up regular self-checks and to be engaging with their surgeon.
Because this was a question that came through in the patient questions. It was, why is it okay for women to now not get implants that have been recalled, but it's okay if you've already got them to keep them in? And so we might just get the doctors to refer to really talk about that risk and benefit of keeping the implants in.
So I think it goes down to the relative incidence of this tumour. So as Miranda said, there's no indication to preventatively remove these implants if there's nothing wrong. But going forward, I think the decision by the TGA was to try and limit new cases going forward. So there is this sort of, this gap.
Balance.
Yeah, this gap between what to do with women who have these implants. And I think the explantation surgery is not without its risks. So, as practitioners, we have to advise patients, look, there are considerable risks to having an explant done, and those risks currently don't weigh the benefits of ongoing surveillance.
I think too, just to add on to that, Anand, is that we get a lot of women and they ask, look, what are some of the long-term consequences of living, with these implants in? Is the risk going to increase with time going on? Or, also, if I do get to get them taken out, will there be some kind of a Medicare or, anything that can sort of support me along that way? Because a lot of women don't have the money to get them removed.
And that is obviously consideration as well, isn't it, for patients to see whether they they can get the implants out. So, and we might just talk about the recall of the implants. Miranda, can you just, I know it's quite complicated and there's an extensive list, but can you just take us briefly through which implants have been recalled by the TGA, just in general terms?
Sure, Sophie. So the decision was made to recall 8 models of breast implants that are produced by 4 manufacturers, but each of the manufacturers does produce multiple models. So essentially, of the 8 products, 7 of those are macrotextured and 1 microtextured. But the TGA is aware that this is something that we're continuing to learn about. We don't know everything about ALCL and the causes of it. It's also a latent disease, so there is quite a lag before it's presented. And so in order to take a forward-leaning approach, we've imposed conditions on all breast implants that remain available in Australia to increase reporting and also really support consumers to have more information about the devices that they're having implanted.
And I guess the question might be, still, Miranda, for you, is why aren't all textured implants off the market now?
So in looking at the review of all the breast implants, there was a range of information taken into account. The TGA undertook quite extensive laboratory testing on the surface texture of devices and looked at the manufacturing techniques involved. We also looked at a range of clinical information presented by the manufacturers themselves and took into account advice from our working group and from the consumers as well. The reality is that breast implants have an important place, and removing all breast implants from the market would have adverse consequences. So in looking at the decision, what we're trying to do is benefit risk analysis and consider what is the point at which that benefit tips. It's a very hard decision to make, and it's one that people will have many views on. At its base, the decision to make suspension decisions has based on where clinical evidence has some gaps in it, and that's a condition we've put on the suspension, and also where those particular breast implants have specific links to cases in Australia, or where they have claimed equivalence to breast implants that have specific links. So their manufacturing technique is the same, or their surface texture is the same. So there are lots of similarities between the products.
So that might be a good point now just to talk about risk, because the risk does differ based on the type of implant. So maybe can I ask our panel to take us through the different grades of implant and how the risk changes with those different grades?
So we sort of classify the roughness and the surface area into 4 things. So it's grade 1, 2, 3 and 4. And it's particularly the grade 3 and 4 implants that are have a bigger risk. Can be as high as about 1,900 for some of them. And then for the lower textured implants, the risk that we have is anywhere between 1 and 15,000 to 1 and 36,000. But there are other implants out there that haven't been on the market for long, and we just don't have the data on those yet. So it's probably important to ask, if you're going to consider breast implants, ask your surgeon which type of implants they use, and they can give you the numbers that we have based on our data so far.
And so what exactly should patients be asking in terms of if they're thinking about implants? What are the questions that they need to ask so that they can then make a decision about whether they want that particular implant?
Well, you've got to basically have an in-depth conversation with your surgeon about why you're choosing this particular implant, what is the benefits of it, what is the risk that we know so far of developing ALCL. If it's an implant with a slightly higher risk, why are you using that as opposed to a smooth or a micro-textured implant? You've got to go through that discussion with them. There are benefits to using them in certain cases. And, in terms of textured implants to improve capsular contracture rates and migration, which are 2 big areas of complications that are much more common than ALCL.
And Anne-Marie?
Look, I think the point here is that when anyone goes and sees a surgeon or a specialist, of course, you're always going to listen to them. And what I like to see is that women are informed, but they do research. They do research in a way where you really look at, okay, so what is it that I would like to have? Why I'm going to have these implants? But not only that, what are the benefits? And ask informed questions. So, okay, these are the implants that you'd like to, have me have, but why is that? What's the difference between this implant and this one? And be okay with, asking what are some of the experiences that you have as an individual surgeon in this area. So do that research before you make up your mind.
And another thing that we'll touch on now is also about follow-up care, because that's very important as well, isn't it, with breast implants? So it's not just something that you go and have and that you forget about it. So how important is what sort of follow-up care should women be getting when they get breast implants?
So I've been advocating that breast implants are not lifetime devices, and in fact, the longer they stay in you, the more risk of things going wrong. So I agree that I don't think it's good enough to put an implant in and not offer some sort of ongoing surveillance. Now, there's always argument as to what that frequency of surveillance is, and so you could do a clinical exam each year or every second year, but you need to match it sometimes with some imaging as well. It varies from surgeon to surgeon, but I do think we need to start offering this as part of a standard of care.
And I think too, on that, Anand, is that when you start getting that relationship with your surgeon, that you are okay to reach out if anything comes to mind, or if all of a sudden it doesn't quite feel right. I think that in the past there's been a bit of shaming about having implant, but we know there's thousands and thousands of women a year that gets breast implants. It's not uncommon. If you were to have any, let's say, a hip replacement or anything like that, and something was wrong, you'd go to your doctor, you go to your surgeon and say, hey, I'm not feeling quite well around that. And I think it's normalising that breast implants is something that a lot of women do get for certain reasons and individual reasons as well.
Yeah.
Have that relationship with your surgeon where you can reach out and ask any question without feeling like, is this okay? And not have that shaming feeling around it as well.
There are two benefits, Anne-Marie, as well, I think. Benefits for the patient, because every year when you come back, information might change.
Yeah.
So there's new information that there's an opportunity to discuss with the patient. As women get older, there's also risk of breast cancer. So having implants and screening for breast cancer is something that's really important. And we've found that they may not be getting breast cancer screening if they're worried about implants. But I think the other benefit is actually to the surgeon, because you really get to see your own results over time. And you learn that what you do today can change significantly as time goes on. So I think I'd encourage clinicians to follow up patients, because you learn from your patients and you learn from your own data.
And I think too, that when you do get a lot of paperwork, which you do with any surgery, is that you really sit with your surgeon and go through that step by step. And if any question comes up, be okay with asking those questions at that point of time, because they're there to support you, and it's a partnership, and it's a relationship that's built on trust, and that will take a lot of the fear away as well.
Yeah.
So one of the common questions that we've had for people or pre-registering for this webinar is, for women who have breast implants, can you test for ALCL with a blood test? So who'd like to address that?
No, you can't. Simple answer.
And why not? Take us through, why can't you test it for, and why can't we do a blood test to see if you've got ALCL?
Because the disease itself actually sits usually in the fluid around the implant or in the capsule around the implant. So it's not until, potentially later it can spread further, but generally most women present with very early stage disease, about 87%, and that's confined, which is good because it's very treatable at that stage, but you just won't pick it up on a blood test.
So with the fluid, how much fluid do you need to take to test properly for ALCL?
Generally, you want to test, the amount has to be enough to you can safely remove the fluid without damaging the implant, because you use a needle to remove the fluid. So about 50 mils is what they generally say is a safe amount that you can easily drain to test.
But I'd like to add that the majority of women that we've seen with this, it's not a little bit of fluid. It's a significant amount of fluid. It's not something you would ignore. You'd wake up and, one breast would be quite swollen, difficult to get into.
Yeah, and we get a lot of questions from women that, what are some of the symptoms? Is it just fluid, or is it that my breast is hardening, or I've got a rash? Could that be it? So what are some of the symptoms other than fluid?
Yeah, so what do you, when patients come and see you again, what are you generally seeing, or what are you commonly seeing as symptoms that would lead you to think that this patient might have ALCL?
It's usually a seroma, so a collection of fluid that happens without any necessarily preceding history of trauma or anything like that.
And what does that sort of look like? Can you just sort of take us through what that might look like on a patient?
Looks like a swollen breast. It's, we don't have any cases of disease in both breasts at the moment, so it's generally on one side, and that breast will look a lot bigger and swollen, more swollen.
And Ron, does that fit with what you've seen?
Pretty much. I mean, it's usually painless. It's not associated with any temperature or redness, purely like a swelling without many symptoms apart from just the swelling itself.
Yeah. I think...
you go.
I was saying, a lot of women get their implants ultrasounded and that because they might have had, some other issue, and they'll detect a small amount of fluid, and that's not abnormal around a breast implant. It's when it's a bigger volume generally, but, if that fluid does build up to something more, it's important to go and see your doctor to get that tested.
And is that why it's so important to go back and have checks and to see if that fluid is building up?
So I think the moment a woman presents with a seroma, my feeling is it really should be properly worked up. It can't be ignored. And where possible, as both my colleagues have said, you need to sample it and test it. There are many other causes of fluid swelling, but you need to really exclude ALCL in that setting.
And Anne-Marie, is that happening with patients that are coming to you? Are they what are they saying to you about their experiences in terms of if they have fluid or they have some concerns? Are they getting proper follow-up care and getting those tests done?
I would say yes, some, absolutely, and that's a fantastic thing because we do have some amazing surgeons in Australia. There are a big group that they might go to the doctor and they don't know what to do. And I think it's being downplayed a lot. Some surgeons, they no longer are active, so they can't find their past surgeon. Sometimes their information of their implants and the details are no longer there because, that it might be past the 7-year period. So I think that, that there is a large amount of women that do feel like it's been downplayed. You'd be right, because it's fairly rare. And, so yes, I think it's a bit of a mix.
So we might just follow up that point about what should women do if, for example, they don't know what type of implants they have, their surgeon might have retired, they can't get that information. What should they do just to find out more about what's going on with them?
There's a few ports of call. So clearly, if your surgeon is retired, then one option would be to go to the hospital where you had the original surgery. So a lot of hospital records are kept a lot longer, as we found. Actually, Anna did a lot of the work in terms of finding out which implant types are involved. So that's one port of call. And then there are registries now. So prior to the ABDR, there was the breast implant register, and that you can contact them and ring them and say, look, this is my name, my date of birth, am I on the register? And that's another way you can find it. And then actually go through a lot of paperwork at home, because often women say, I don't know. And I say, well, do you have a file with medical stuff? And just go and rifle through that, and sure enough, they've been given a little card. I had one patient that brought in, I think, a 30-year-old card of a Dow Corning implant.
Oh, wow.
And she says, I didn't even know this was at home. So there are different ways of getting that information.
And we do get questions quite often. So how do I know if my surgeon is going to be the best one? How do I know if this surgeon is exposed to a lot of experience? How do I really know, other than perhaps asking questions, looking at their website and looking at some of the credentials? So what's your answer to that?
Yeah, what should people do? I mean, because often looking at a website can be not necessarily a good indication of someone's expertise or qualifications, or is it a matter of going and actually just having a consultation and asking the right questions, asking about their experience, asking about what sort of follow-up care they might offer?
I'm happy to take that one. Look, I think that don't forget your GP, because general practitioners have a wealth of information about a lot of stuff that happens out there, whether it's good and bad. So, I think the GP should be included in this process. I mean, I know a lot of... That would be one piece of advice. The other thing is, I think a lot of it depends on how comfortable you are.
Yeah.
I mean, I've been a patient a few times,
Yeah.
and it's that level of comfort and trust,
Yeah.
as you say. I think it's really important, and I think people are pretty good at sensing that. I hope they are anyway.
Most people.
So, Dr. Bezzi, what would you say to women who might be thinking about breast implants? What sort of questions should they be asking doctors before they go down that track?
Also the level of experience. So how long have they been in practice? Have they done this procedure many times before? What type of training, specific training have they obtained doing this procedure? And also looking at feedback from other patients, maybe talking to other patients. If you couldn't find any other information, that's often a useful source.
And one of the big issues I know with, because I've done lots of stories on medical devices, including breast implants and others, is the issue of informed consent, and whether patients really understand what they're having, implanted inside them. So I just wanted to touch on what's being done to improve informed consent, both from doctors and also maybe from a regulatory point of view.
Can I suggest we use the term informed educated consent?
Sure, yep.
The reason why educated, I think, is important is that different patients have different levels of ability to take in information. So, giving a detailed bit of information to someone who perhaps may not, get most of that, you need to then give it another avenue in which they can clearly understand it. So I think informed consent is more than just a bit of paper or a tick box. It's actually connecting with that patient on a level that they can understand, and you can educate them, and they can make a real decision based on what they know.
I agree. And you should, for a lot of these surgeries, it's a big decision. So, you probably want to go back to your surgeon more than once, to actually go over things again, because you're only going to take in so much in one consult. So it's, I tell my patients, go home, write down all the questions that you have, because when you come back, hands down, you're always going to forget something when you're actually in the room. So if you have this list, you can go through it. And if you're not happy or comfortable with your surgeon, you can ask for a second opinion, or ask your GP to refer you to someone for a second opinion.
I think that cooling period is really, really important, just to because it's an emotional thing and it's a big
It
thing
is.
for women. So having that cooling off period just to deflect and maybe even bring your partner or bring a good friend to the, to that meeting to ask some other questions that you might not have thought about at that point of time, just so that you can come from different angles, because it is an emotional thing for a lot of women.
Yeah.
I was going to say the onus on us as healthcare professionals is to make sure they understand the nature of the surgery. That's part of the informed, educated, was it educated?
Informed, educated consent.
And Miranda, what from a regulatory point of view, what is being done or what can be done to help empower women so they can make that educated and informed consent when they're sitting in a doctor's surgery?
So as part of the review, all products were given new conditions, and that was to enhance information in two different ways. One was to enhance the instructions for use, which go to surgeons, and that helps health professionals stay up to date with what's evolving knowledge. Also to introduce what's called a patient information leaflet, which helps consumers understand information about the product at a consumer level, so not at a technical scientific level, but the kind of questions that normal people like us might have. And that's a really important part of educating both key groups here. In fact, the condition comes into effect today.
Right.
So we've been working very closely with manufacturers and sponsors to ensure that those products are available. We've also got a really great breast implant information hub available on the TGA website, which goes through some of those questions you might want to ask, and it's keeping an evolving timeline of what's happening with the knowledge of ALCL. So certainly a resource that we'd recommend to people, whether they have implants or they're considering getting them.
And I was going to ask, would that be in the future building on getting some services around Australia? Like we've got breast cancer clinics where women can come and get their breast implant checked and screened, and just have someone that's really knowledgeable in that area without having to make too many big appointments. And
So Dr. David, do you want to just talk about the clinics that you've set up and that you're hoping to roll out?
Yeah, so I think that, once again, it's impossible to deal with this demand. I mean, certainly since, regulatory action, there are a lot of anxious women out there, and I understand people are finding it difficult both to get access and also from an affordability point of view to present for assessment and then potentially treatment. So don't forget your GP. So I want to go back to that before we start talking about the clinics. They're a great resource, and actually we're working very actively to try and educate general practice about breast implants, because a lot of them don't know about them. So there are articles that we're publishing and information, I'm sure, that will be available so that your regular GP will know what to do. So I think that's the real solution, rather than opening more clinics, to have a level of expertise at that level. Now, the clinics, look, there are public hospital systems which Anna can speak about. So there is a public hospital avenue for explantation surgery, on Medicare. And then what I've started, and it's still a long way to go, is to try and work in the not-for-profit sector. So working with universities, working with partly with government funding, but then also increasingly leaning on the social responsibility of companies to say, look, you've got to help solve this problem. But it's still early days, and there's a lot more work to do.
Now, we just had an interesting question come through, because I think we talked earlier about the breast implant registry, and the question was, does the breast implant registry cover implants that were put in like decades ago? And also, what about if you have your implants put in overseas? So can we just cover that for a moment? Maybe who'd like to take that?
So we were just trying to pinpoint earlier the exact date that the ABDR came into effect, and it's around 2015. And it does have a really high subscription level amongst surgeons. It's 90% plus, so that's encouraging for people who've more recently had implants.
And does that include all types of surgeons? So like plastic, cosmetic, no matter what type of surgeon?
Yeah, that's that whole sphere. It's about a 90% take-up rate, which is really encouraging. Historically, there has been less record keeping in that regard, so people certainly 30 years ago may not have, and it's certainly not a default for people who may have had implants overseas. But there are options for someone who did travel and have surgery overseas, or had surgery before the registry was stood up, to register their own details, and there's some very accessible patient information pages on that ABDR website.
Okay, so that's obviously, and we can put links to that.
We can make them
along
available.
with this as well.
I think
Okay.
these databases are really valuable for us as scientists too, because then we can actually look at that data long term, just like they have in orthopaedic joints too, and actually assess these implants over time, and time is one of those things, you know, what's
Given
on the
sort of-
market now,
yeah.
you don't know how that's going to behave until you get long-term data on it. So, you know, again, ask your surgeon if they're a part of the registry, and also ask them about what long-term follow-up they're going to offer. And, you know, as we alluded to with the, you know, if you are going to get implants overseas, it's one of the things you need to factor in. And any surgeon that you see, you know, what are they going to do if something goes wrong? Because surgery is not a, you know, 100%, you know, guarantee that nothing's going to go wrong. Even if everything is done right on the day, there's always going to be a risk.
So we've had quite a lot of sort of quite technical questions about women who might have implants and have some symptoms. So I think it's worth going through some of them with this panel today. So one of the questions was, some women have had swelling in the breast. The pathologist tried to drain it, but there wasn't enough fluid. What advice would the panel have in that situation? What should happen then?
Well, I think clearly there needs to be ongoing surveillance. Just because there wasn't enough to sample today may not mean there would not be enough, you know, in 6 months. So I think it's just another reinforcement that if something is wrong and you're worried about it, just to keep going back and getting regular checks.
And is that something that some of your patients are coming to you saying as well, Anne-Marie, that you know that has happened, that they may have had some symptoms but it wasn't enough to get a diagnosis?
Yes, and I think because it does take quite a few years, you know, or to get the ALCL, that if you do have that fluid, keep getting checked. But I think it's just, you know, ask questions and be okay to reach out, because we all know that if you live a life full of fear of the unknown, it can be very stressful for a lot of women. So be okay with having a strong voice. Be okay with asking experts. Be okay with researching. And, you know, it might not be the fluid part of it. And as we know, can be natural to have a little bit of fluid around your implant, but with the LC seems to be quite a lot more fluid. Is that right?
Yes, I think if let's say a woman has had a bit of fluid but it's not enough, then the clear message should be, look, this is not normal, so you have to come back, and in fact some sort of recall to make sure they don't go off thinking everything's fine. Because it might be fine today, but it may not be in 6 months or 12 months. So I think linking back to regular surveillance is key.
And we might just mention that fact about anxiety. So with the women that contact you, how anxious are they about this? How worried are they, that particularly when there's stories in the media about this condition?
Well, if you look at anxiousness and feeling stressed on a scale from 1 to 10, I would probably say most of them around 11. And I think it's just that it is a very big topic. Breast implants are a big part of society. And a lot of women, they have implants because of different reasons. I mean, they might even have had breast cancer and so forth. So there's a lot of different kind of fear factors. The fear goes down with having information like we're doing right now, being able to have more kind of a fact-based evidence with it. And I think that women are starting to go, okay, I need to reach out to my doctor or GP. I need to go and see the surgeon. I need to find out who's the expert in this area. What are some of the recent research about it? And the fears tend to go down. So my advice is, don't live at home in fear because you feel shamed. Don't think that it's not okay to reach out. Don't be afraid of being vulnerable, because it is a big part of our life, and it's not something that you want to keep having on, because the stress doesn't get better. It will get worse with time. So be okay with getting the support.
Can I also say that I think we are in a very good position in Australia. I think I think that's a message of reassurance. We're all sitting here, we're collaborating, we're collegiate, we share data and research, and we work with the regulator, openly. So I think women should take comfort in the fact that there are some very good people working to get answers and to come up with the right decisions to help them. And I think Australia can be rightfully proud for actually, leading the way in some ways, don't you think?
Well, certainly with the collection of data, we've been able to have good data and sort of pick this up relatively early on. We've got some other sort of technical questions that have come in, but I think it's important to get these questions answered as well. If women decide to have surgery, I might just go to Dr. Locke-Wilkinson to explain what's the difference between en bloc and capsulectomy. Can you talk us through those?
Yeah, so an en bloc resection refers to taking out, the tumour and all the surrounding tissues in one unit, whereas a capsulectomy itself can be partial or total, and that's taking out that capsule, so the scar tissue that forms around the implant, but not necessarily all, things like the breast tissue or the ribs or anything around it. So for ALCL, we recommend a total capsulectomy, so taking out the whole thing. But you may, if you don't have ALCL, doing a capsulectomy, will happen for different reasons, and whether you need the whole capsule out or not depends on the type of capsule it is, whether it's very thick, inflamed, how plastered down it is to the ribs and things like that.
We get a lot of questions about, okay, so if I get my textured implants removed, is it okay to get then smooth implants put in?
Mm-hmm.
Yeah, and what would you say to that question?
It depends on the individual factors. If they required another teardrop implant, you'd probably be looking at another textured implant. Depends what they sort of need for their look. If they're adamant on having smooth implants, then you might have to adjust your surgical approach to them.
We might just explain that a little bit for the audience. Some will understand the difference between smooth and textured and why, the benefits versus risk of smooth versus textured, because some people might think, well, if the textured are more risky, why don't we just stop using them? And it's not really that simple, though, is it? So who would like to address that?
I can speak to that. So as Anna said, we've looked at a grading system based on actual measurements of surface area, surface roughness, and it goes from 1, which is smooth, all the way through to 4, which is very rough. And so for the grade 3 and 4 implants, the ones on the rougher scale, there are benefits. If the implant is rougher, it will stick to tissues and less likely to move. The other benefit of a textured implant is they come in an anatomic shape. So the benefits of those is if you've had children and there's a bit of loose skin, then that will actually...
So they're more likely to get... Do they give you a better result?
And the thing is a bit woolly because once again, in this space, there are a lot of claims, but there's not a lot of data.
Right.
So this is where I think we get into, and as Miranda was saying, it's very difficult to tease out what the real benefits are when there hasn't been this prospective, comparative data to say this is better than that. But nevertheless, we in Australia have used textured implants for a long time for that reason. Smooth implants don't have that capacity, and so they do tend to move around if there are loose tissues or if you need fixation.
Okay, so another question we've had come in was, what should women do if they, and we've sort of addressed this, but I think it's worth going into a bit more, if they have the record implants and they're having symptoms and they don't feel supported by their doctor or surgeon that they have at the moment. So they might go back and feel like the doctor or the surgeon's not taking them seriously and sort of dismissing them. What should they do to make sure that they're getting good follow-up care and to put their fears at rest?
I would suggest see your GP. Look at seeing possibly someone else that they would recommend, and they possibly have a better, more comfortable relationship with a new surgeon, if that was the case.
Yeah, I agree with Ron. Good GP's worth their weight in gold, so get a good GP, see them regularly, and they will know who to refer you on to.
And we talked about this earlier, but what if some women might want to have an MRI scan and Medicare won't cover it for a ruptured implant, for example? If they can't afford it, what can they do to get that resolved?
So ultrasound is affordable and is a relatively good screening tool for picking up rupture. It's not always the case, but most of us, based on clinical findings and an ultrasound that shows a rupture, would say this is ruptured. So it's not necessary to get an MRI for every potential rupture on ultrasound, so that's the first thing. And I do know that the government has now introduced a rebate for MRI for proven ALCL for part of the workup, and I guess, if this demand continues to increase, we could lobby government to provide some sort of support for imaging.
What about if it's for a patient? We had a question on this. If a woman who has swollen lymph nodes, for example, and feels tired, so she might feel like she has some of the symptoms, could she get her lymph nodes biopsied, or do you need to be further down the track?
Kind of depends on what the other symptoms are, because there's a lot of causes for swollen lymph nodes. So again, getting your GP to do a good and thorough workup for that.
To sort of exclude other possible causes.
I think if you have isolated lymph nodes, then that might be an indication to go and test further. But it depends on a lot of the clinical history and other things.
Also, the ultrasound will have if they looked a bit worrying, have a specific appearance, a swollen lymph node might be reactive, which is fairly benign, and you wouldn't want to biopsy that necessarily.
Is that something that, Anne-Marie, that some of the women contact you about, that they might have these symptoms like lymph nodes or feeling tired, and then they're concerned it might be the implants?
I think that pre all of the information about ALCL, people would just go, you know what, I'm tired because I work really long hours, I've got children, I'm doing a lot. And, maybe I'm a little bit sore in my lymph node because, I went to the gym and I worked out really hard. But now we've got this information and all this data, and I think that it's all of a sudden, this is why I'm tired, or this is why I've got thin hair, or this is why I've got a rash. And that's not always the case, as we know, but I think that it's, yes, lymph nodes is a big thing. The rash is a big thing, having the fluid, tired, perhaps thinning hair. Those are sort of the things. But like we've been saying, go to a good GP. And if you go to a GP that has no idea and that doesn't know, or maybe you don't feel really good, then go and see another one. I mean, there's lots and lots of choice out there. And the same with your surgeon. If you can't find your surgeon, and if they're not really wanting to support you in that way, well, there's lots of other surgeons out there.
So we might just talk to the audience a little bit about, and we sort of touched on it, the breast implant-associated illness. Could one of the physicians take us through what that is and how seriously is that taken by the medical profession?
Okay, I'll take that. Look, breast implant illness is one of these things that is emerging, but it's an old story. It's not a new story.
And what would be some of the symptoms if a woman has breast implant-associated illness?
Sure. So it's an emerging entity in that in the 90s, a lot of women linked autoimmune disease to breast implants. That actually led to legal action in the US. So there's been this link potentially between chronic illness and breast implants. It's been out in the literature for a long time. And if you look at the data, as I said, there's some that support and some don't. So I think that we're starting to think about processes that start to be triggered by implants, not just breast implants, and it's inflammation.
So more inflammatory processes that might be switched on by having an implant.
And so the short answer is, do we believe that some women, get chronic illness from implants? I think the answer is yes, but we just need to have more information, more research, more data, tease out what symptoms are related to chronic inflammatory processes from the implant or chronic inflammatory processes from something else. Yeah. And that's really difficult. It's not easy research, but we're starting it. And
I think we hear a lot of women saying, so they have contacted the GP or they have contacted the surgeon, and look, it's very, very unlikely that that's you. It's very rare, or we don't see that, ever. And so a lot of women don't feel that support because it's being downplayed. So what's your advice when we see that?
I think you need to keep an open mind. I mean, a lot of people can be dogmatic about things and then proven wrong once the research and the evidence comes out.
That's true.
So I think if a patient is sitting in front of you and has a problem, then as a doctor, you've got to listen to them, take their complaint seriously and do some proper investigation. I mean, that's part of being a good doctor.
And as you know, when we're dealing with the unknown, a lot of the time your mind will go to, oh my goodness, that's it, I'm done, I'm going to die. So what's your advice when it comes to that?
Reassure people.
Anna, do you want to?
Anna?
I mean, we defer to you. I think it's very difficult.
It's a difficult area.
It's really difficult.
Knowledge is power. So, you need to go, you have a right to go back to your doctor, ask them these questions, make sure your GP has ruled out other causes.
Things.
But, if you really strongly feel that way, then you can have your implants out. But whether, that can be done in the public or the private, that's sort of the catch. So you've got to think about the implications of that too, financially, the risk of having explantation surgery itself.
Yes.
Like that.
And my plea to that in that setting is that there is a golden opportunity to capture data. So it'd be really good to know, about these women, about why they're proceeding with explantation, and more importantly, actually analysing some of the tissue that comes out, maybe looking at some blood tests. So there is a framework for a really good research project, which can be done and hopefully provide answers.
And for us surgeons as well, we should remember that we're removing implants. We need to actually fill out the ABCR form to say we've explained and not reinserted.
Yep.
We've got a couple of questions which we want to get through about late-stage ALCL. So we've got a question saying, what research... this is from Terry. What research has been conducted on late-stage disease and treatment options? Can we cover that?
So this is, I spoke to Miles Prince actually, who's a professor of haematology in Melbourne. And so the standard treatment is still CHOP, which is chemotherapy and prednisone. And then if they fail that, there's brentuximab, which is a monoclonal antibody conjugated with a chemotherapeutic agent, which has got amazing results. And then unfortunately for someone who fail that, then it's bone marrow transplant.
Okay.
So that's kind of the sequence. Now, the really good news is that there's very, very few women that get to that point. And that may be because we're picking it up early through awareness, so that's terrific.
So Anna, I think, what was the statistic you quoted earlier about if it's caught early?
Yeah, so it's about 87.5% of patients present with stage 1 disease, so in the fluid or the inner part of the capsule. And to date, we've had no deaths in this patient group, and the 5-year survival is 100% in those patients.
Which is good, and that's good, I guess, also to keep in perspective in relation to other forms of cancer that don't have anywhere like that success rate and survival rate.
Yeah.
So we've covered the point about brentuximab, and there's. I just wanted to go back to Anne-Marie for a moment. What struggles are you seeing in your patients that contact you, the women, in terms of the struggles they're facing in relation to testing and diagnosis and treatment? Are there some common things that pop up with those patients, those women?
The common theme seems to be the lack of knowledge from perhaps the GP or when they're going to get their fluid tested. So there's been a real kind of unsureness about how many mils needs to be tested to kind of get the accurate outcome.
Well, let's be quite specific. So what should, how many mils of the fluid do the doctors need to take out to do that proper testing?
Well, we nominated about 50 mils before, but it's essentially what the ultrasonographer is comfortable removing without damaging the implant. And as Anand said, this usually presents with a lot more fluid than that, so that's not usually an issue. And if it's a small amount of fluid, then we monitor it to see if it progresses. But that's where you get the patients worried about, is this an early stage? But you just got to reassure them and make sure you get them back and not neglect them.
There's another question here. Have there been any, this is from Gina. Thank you, Gina. Have there been any cases of ALCL with textured implants where the seroma fluid was negative, but the capsule or the scar tissue tested positive? Has that ever happened? Or is that unlikely to happen?
I don't think in our series that we had any that are negative fluid and then a positive tap. We've certainly had a few the other way around, so a positive tap and then negative pathology. Right. And that's because the tumour cells are just in the fluid alone. So we think that there's actually two distinct versions of this, one where it's mainly fluid and held at that stage, thankfully, and there are a few that maybe bypass that and go to more advanced disease. And there's a lot of genetic work. I won't go into the details, but we're looking at genetic risk as part of it.
Another one that comes up quite often is that, is it okay if I just get an ultrasound? Will that pick it up?
It's clinical examination and ultrasound.
Yeah.
So you need both.
So does the person need a PET scan and a breast MRI?
No.
No, only if it's proven disease and you're working them up.
So why don't we be quite specific? Let's just step us through the exact steps that you would like that a patient needs to have if they've had breast implants, they're concerned. What would you do step by step to sort of either to rule in or rule out ALCL? So what needs to happen?
So I think your first port of call is either your original treating surgeon or your GP to do a workup. If you do have that fluid, then an ultrasound with a tap of the fluid, and that gets sent off for some special tests that we look for certain markers and that with immunohistochemistry to define whether it is ALCL or not. And then if you do have ALCL, we do an MRI and PET scan as well.
So that's the standard workup that women should get. And is that happening, Anne-Marie, from the women that are coming to you? That if they're having symptoms, are they generally going down that pathway of?
I think there's definitely been a big change in exposure of information, and it's happening more, but there's been a big gap where that hasn't happened. And that's created a lot of confusion because people reach out and then information on social media is being shared and it's creating a lot of fear. Kind of like, oh my goodness, I haven't ticked that box. And that's where I think it's really important. Have that list. Make sure that if you're seeing the GP, so that you can kind of follow a procedure there.
And so just with that, how satisfied are you that the regulators are doing enough to keep women safe and to keep track of what's going on with this condition from the women that come to you? Do you think enough is being done, or would you like to see more being done?
I would absolutely love to see more being done, and in a way where the information is just becoming common knowledge. And I think that, so that women don't have to go and search for it and really work hard to find that information. It should be something that is right in front of us, and that's in terms of GPs knowing exactly what process they need to do, the people that's testing the fluid needs to know exactly what to do, surgeon as well have the same procedure, so it doesn't matter if I'm seeing this person, that person, I know I'm going to get the best practice every time. Have those clinics around Australia where, I can go there, I don't have to talk about intimate people, I can go there and they know exactly what it is that I'm dealing with, and I can have that. It makes it more of a normalise it.
Yeah. And so from the regulator's point of view, what's being done, and is there anything else being planned for the future to improve what's happening for women who might have these implants and be worried?
So I think certainly, Anne-Marie, we have seen a positive change. That information's starting to get out there, and that's because we're leveraging some really great consultative groups we've stood up. So we're working with the major colleges through our advisory working group on breast implants. So that helps us not only get information about what's happening at the cutting edge of research, but also find avenues to push information out to more surgeons and to look at opportunities to do that with GPs as well. We've also established a consumer working group. So we have women who have had an ALCL diagnosis speaking with us, so that we have that very human element about the questions that are asked and the best way to communicate that. And the patient information leaflets have all been approved with key input from that consumer group. So it's not a scientist saying, yeah, I think that's consumer language. It's women who've been through ALCL who've reviewed those and given some really excellent feedback about the level of language, the way information should be structured, and even I think, that's a really good point about how much information, sometimes too much information, you start screening out, getting that balance right. Yeah. We also work very closely with the Commission on Health, Safety and Quality, and with the jurisdictions, and so those dialogues are beginning. But I think it's a good start, but there's certainly more to be done.
And I agree, less is more when it comes to that information, and I think, that it just makes it more simple.
So with the patient information sheet, at what point, or should every woman going for a consultation be given that sheet, or how do they access that information?
So the concept behind the information leaflet is it is given before surgery, and that it is a material to help that informed consent discussion. Down the track, more generally, for implantable devices, there will be a requirement that's being slowly introduced for people to also have an information card, which is more their ongoing reference about the model, the type, so that people have that information as well. But the information leaflet is specifically to inform those choices up front.
And Nadia?
So I was going to say that, look, we focus a lot on women and ALCL, but I think we should really be looking forward to women who are thinking about having breast implants. So I think it's a great opportunity to learn, as Anne-Marie says, up until recently it was a little bit all over the place, but we're now putting structures in place. And so I think a lot of this information shouldn't just be about women that are worried about an implant that they have, it's about women who are thinking of getting an implant.
That's right.
So, to go forward to the young, perhaps not so young women that are coming for surgery and looking at really patient-focused resources for them so they make an informed, educated.
And I think that the point there is that it's not because implants are bad, it's just having the education so that you can make an informed choice. You've done that research and there isn't any nasty surprises that you weren't aware of.
And I was just one of the questions we've had is from David, who is wants to just cover the issue of, first of all, how many, I think we referred to it in the slide, but we can go over it again, how many cases there are in Australia and New Zealand at the moment. But also, what is your prediction of the numbers and the risk going forward for for that group, so that women who might be thinking about implants can sort of weigh that up?
So the total as of January, end of January, is 107 women have had ALCL with implants from Australia. There are an additional 5 that have had ALCL who are Australian but had implants overseas, so it's interesting. So the total's a bit more.
So would that indicate that the rate is higher?
So we've got 3 snapshots. Anna was involved in 2 of those, and each time we've looked at, so from point 1 to point 2 was a 40% increase, from point 2 to point 3 was a 56% increase. So we're looking at point 4, soon enough, and we expect that those numbers will continue to rise.
So you will expect that more cases will come forward?
Of course, because a lot of textured implants have gone in, and there's a long lag.
I think there's, I think we have a social responsibility too, because there's a lot of stuff on social media about, young women and their bodies. It's like that Kardashian effect. They all want to, get plastic surgery these days, and a lot of these girls are sort of. A lot of them are young and impressionable, and there's different groups that get implants. There's the purely cosmetic group, then you have the groups that, have maybe congenital deformity or something, and then you've got our breast cancer group, and then also the mummy makeover type of groups, the women that are a little bit older and, have had their kids. And I think particularly that first group can be really impressionable. So I think, it's really important to find ways to them to be informed. As well. Everyone needs to be informed, but I think at that age, you are really impressionable with your social media, and us as doctors have to be responsible with what we put out there as well.
And do you think, Anna, that perhaps they're also a bit vulnerable as well in terms of being a little bit insecure about the way they look?
Absolutely. And, there's been fads in plastic and cosmetic surgery too, and, the decisions you make when you're 19 are going to be different to the decisions you make when you're 40. So...
And I think with those different groups too is that we see that you will have that group that will want to show off that, look what I've just had done and look at me. And then you get that other group where they don't do it because they don't go and say, hey, did you realise I just had my breast done? So it's like, if you've got glasses and then you get surgery on your eyes and all of a sudden you don't wear glasses, people go, oh, what's happened? You've changed. Something's different. Okay. Oh, yeah, well, I had my eyes done.
Yeah.
But breast implants is a little bit different because it's not something you go out and actively talk about. Let's have a cup of coffee and let me tell you what I've got done. So it's a different way of thinking and connecting and communicating with.
So we've only got a couple of minutes left, so the hour's just nearly really flown by. So what I want to do is quickly go around to the whole panel, just very briefly, to just in case there's anything we haven't covered or what you'd like to sum up your thoughts, a key message that you'd like the audience to take away from our discussion this morning. So do you want me to start with Anand or start with Miranda up the other end?
Go the other way, because I feel like I'm in the hot seat.
I've only got 2 minutes left, so very short and snappy.
Well, I think the hashtag for today, speaking about social media, said it all. Be informed. It's the best thing you can do. Ask questions, whether you've got implants or you're thinking about them.
Okay. And Anne-Marie?
For me, it's about informed, educated consent. Do your research, but spread awareness. Don't hold back. If there's anything that's on your mind and you're sitting and watching this, make sure that you reach out and get that thought that you're holding on to answered.
I would also add to that, make sure you're comfortable with the surgeon you're choosing, because you're going to have a long-term therapeutic relationship with them, so you have to be comfortable. If you're not comfortable, go back to your GP and source someone else, possibly.
I think, important to think about the potential risks and consequences of, medical device, because, it's going to be in your body for potentially a long period of time, and like any car part, it's going to wear out eventually. So even if you don't get ALCL...
On that point, when we spoke, you were saying, so when a woman gets breast implants, is it a one-off decision, or how often do you need to get them replaced if you want to, say if you get them in your 20s?
Yeah. So it varies, but probably on average every 10 years you might need another operation. So, particularly for the, younger women, that's a long time, of, lifetime of surgeries that they're signing up for. So you've really got to think about what happens long term as well, and potentially short term too. There's always a risk, and you need to make sure that you're educated about that risk.
And Dr. Deva?
For me, I think this is wonderful. I think it's a message of collaboration. And so the power of collaboration across this table between patients, doctors, colleagues, regulators, industry perhaps as well. A lot can be done when humans band together. I think we forget that sometimes. So I'm really grateful that we're all working together on this.
Well, look, our time's almost up, so I just wanted to thank our panel, Dr. Anand Deva, Dr. Anna Locke-Wilkinson, Dr. Ron Bezic, Miranda Lau and Anne-Marie Sage. Lauman, thank you so much for tuning in as well. We got to most of the questions, so it's been great. And as I said, it's been recorded and we'll make sure you can watch it back on social media, on the TGA website, on Instagram and Twitter. So if you've missed a bit of today, the links will be there. So thank you very much.